All right, Jordan. Final video. Let's see if we get interrupted for this one.
All right, you respond to a 26-year-old male who was just shot in a domestic.
Okay, cool. So 26-year-old male got shot. Did he get shot one time, or we just know he got shot?
Yeah.
Okay. I'm assuming law enforcement is en route, or they're on scene already.
Law enforcement just showed up.
Cool. So we'll show up as well, and then once law enforcement determines that the scene is safe, we will go in and we will access our patient. So what do we? So how's my patient? What do I see?
Yep. So you see a male laying supine on the ground with a pool of blood underneath him.
Okay.
He has. You can visually see 3 gunshot wounds.
Cool.
One to his left side of his chest, one to the left side of his abdomen, and one to the left side of his leg.
Okay, so I have a right chest, left abdomen.
All are on the left side.
And left chest, left abdomen, and left leg.
Yep.
Okay, I'm going to call Major Medical just in case they haven't already gone en route, because I might need some extra help here or something. And so with a scenario like this, our ABCs, but first we got to deal with any massive hemorrhaging and stuff. And we have a large pool of blood and multiple gunshot wounds. Chances are we have some massive hemorrhaging that we need to deal with. And so we're going to strip them really quick, get all that clothes off, expose all of these injuries and stuff. And so we have the chest, we have the abdomen, and we have this leg one. And so I'm going to have my partner, are all of them bleeding quite aggressively? Or
the leg specifically.
Leg specifically? Okay, sounds good. So with it, I mean, my real choices with this leg are we can either pack it or we can throw a tourniquet on it. I think with all of the other things that we have going on as well, we're just going to throw a tourniquet on it. Crank that thing down, get it until our bleeding stops.
Okay, it stops.
Cool. And so now that that one is gone, we can focus on these other ones as well. So we have an abdomen, we have a chest. Neither of those are really good spots that you want to get shot. And so with these ones, do I have like big pools of blood and stuff up higher on them as well? Does it look like, or?
Yeah, it's just like you don't.
It's
really
just
tell.
okay. It just looks
pool of blood
messy.
underneath them.
Cool. So we could throw chest seal, and then once we go over there, we would like to take spinal immobilizations because this is a big trauma. But at the end of the day, we need to stop this bleeding first. And so we're going to roll them over. We can seal the back sides as well.
Cool.
And so, and as we do, we'll try to kind of clean it up a little bit before we stick them on there to try to make it so they actually stick.
Yeah.
So we get those. I'm going to move him away from this puddle of blood so that if more bleeding starts, we'll notice it. So he's not just still in that puddle. So we're going to get our initial set of vitals on. And I guess we rolled him up. I think what I would ideally have liked to do is when we rolled him up through the seals on the back and then roll him back down on a scoop stretcher.
Okay.
We can pick him up, pop him on that stretcher, roll him into the ambulance.
Cool.
And so we'll get our initial set of vitals. And then once that EMT has gotten my initial set of vitals, what am I looking like?
You got heart rate 130, SpO2 90.
Okay.
Blood pressure 76/34.
Love it. Cool. So we're going to start going to Ermac aggressively. And so I'm going to take at least one of my friends with me in the back. And so I want to get 2 IVs started, 2 large bores, so the biggest that we can fit in there. I'm going to throw them on a non-rebreather, and we're going to get a bag of fluid hanging. Given these mechanisms as well, I want that fluid to hopefully bring him up some and stuff, but also with this amount of blood and stuff that he's lost, it's kind of worrisome that we don't want to dilute his blood too much, and so we have to be careful of that. So I'm willing to schmack a liter into him and see what happens. And as we're doing that, I'm thinking other things that can help this guy out is I think TXA could help him out. given some of those abdominal injuries. I think Ansef could help him out because it's open, penetrating injuries.
Doses?
So TXA, it's 1 gram over 10 minutes, and then our Ansef is 1 to 2 grams over 20 minutes.
Okay.
And so we get our 2 IV started. We'll get that fluid going. I can have my partner, I'm going to have him start on the TXA first. And as he's doing that, I'm going to call in a phone report to Ermac.
Cool.
Let him know. And so I'd be calling this a full trauma. And so let him know that we're coming to them with a full trauma. We have a patient with 3 gunshot wounds to the left, 1 to the left chest, 1 to the left abdomen, 1 to the left leg. We have a tourniquet on the left leg. Both the abdomen and the chest shots have chest seals on them. Current vital signs, we have TXA going. We have Ansef soon to be going. We're at this point, we're probably like 25-ish minutes out. We're a little bit ways out. And so how are like my vital signs looking now?
Blood pressure after a full liter goes up to about 80 over 30.
80 over 30. Cool.
After a full liter.
Okay. What about my heart rate?
Heart rate.
Still tacky, I'm assuming?
Still tacky. He's about 120.
Okay, what about like my respirations? Like how's he satting? And are these like decent respirations or?
So still like 90% on room air.
Okay.
Respirations.
Even with the 15 liters?
Sure.
Okay.
Respirations of 15.
Okay, cool. How like with it is like GCS 15? Is he with it or?
Yeah, he's with
okay.
it.
Sounds good. How much pain is this homeboy in?
A lot.
A lot of pain. Okay. And so with this lots of pain, worried about giving an opiate just because I don't want to like tank his respiratory drive and stuff, given everything that's going on, and especially with that pressure. And so I'm thinking, so we can get another bag of fluid hanging, and we can like just have it like cracked just a little bit going. But I think given his pressure, and I want him to be able to get the most out of the blood that he does have, and so he doesn't have a perfusing pressure right now. So I think a presser would be indicated for him.
Okay.
And so
what's your presser? What are you doing?
With him, I'd be giving him Norepi, and so we would mix our 4 milligrams in a 250 bag, hook it up to the pump, start at 2 mics a minute, and then titrate that up as needed until we get a systolic over 90 or a MAP of 65 plus. And so we'll be watching that. We have our TXA run. We got Ansef running. He's been able to maintain his airway the whole time, and so that's good. I like that. That makes me happy. And so,
what are you reassessing?
I'm going to be with the fluid.
Yeah, like you're giving him a bunch of fluid. What are you wanting to reassess?
Lung sounds. Cool. So I'll be listening to lung sounds and stuff, making sure that I'm not getting any crackles or anything, making sure that they're still there.
Yeah.
And so if they're not there, then we can correct that. But as of right now, they're both still there.
Cool.
And so we'll keep watching that, keep headed down. Has he been taken to the presser? Has his body been liking that?
His blood pressure goes up to 95 over 45.
Okay.
And heart rate still 120.
Okay.
SpO2 the same.
Sweet. So I would like him to be satting, 93 plus, but I don't think it's. See, that's the dicey part is because he's maintaining his airway, right? So he's doing that. That's good. But if we also look, other indications that RSI could be clinical course, suspected clinical course. This guy's going into surgery. And so he is going to get a tube at some point. But we have the worry of, the blood loss. He's on a presser right now. And so should we deal with the potential problems of sedating him, paralyzing him, and going through that process in the back of the ambulance? Or should we wait until we get to the hospital when they have all of that extra staff and those extra possibilities and stuff? How much time until we get to the hospital?
You got 8 minutes.
8 minutes. Well, this is a scenario, and I'm not sure what I would do in this situation other than crap my pants
Okay.
and hope that whoever the person in the back with me is an absolute pimp. And so we're going to RSI this guy
Okay.
because we can and
Yeah.
because it's going to happen. And so let's secure this man just in case something bad happens.
All right, you got 8 minutes. You're gonna RSI someone the size of me.
Okay, we look at somebody the size of you and we go, he looks like he's about 100 kilos.
Okay.
And so with our 100 kilo patients, so we're going to draw up our doses and we're going to label them as well so that we don't mix them up. And so we're going to draw 200 milligrams of ketamine. And for our paralytic, I'm trying to think if I have any like major contraindications to sucks at this point. I don't think I do. And so we'll go with 200 milligrams of succinylcholine as well. And so we'll get those ready. We're going to get a McGrath with a size 4 blade. We're going to get our BVM with our end title on it. We are going to ventilate this guy. We're going to try to pre-oxygenate him, get him his sats up as high as possible before this attempt. I'm going to get a size for you. I'm going to do a size 7 too. You could take a 7.
Okay.
And so I might pre-attach a 10 mil syringe to that bulb as well. I'll get my bougie out. We got suction with us, so we're all ready to go. So we're pre-oxygenating him. Do we have him in a happy place that we're ready to make this attempt?
Yep. He's
Okay.
still around 92%.
Okay, sounds good. And so we're going to start off, we're going to push that 200 milligrams of ketamine, and then we'll give it a minute or two, let it kick in. And so then we can assess for basically consciousness at this point. So we can like rub some eyelids or something like that. And then after that, we can push that 200 milligrams of Sux and then continue to ventilate him. We're going to check for paralysis so we can mess with his jaw and stuff, make sure he's nice, floppy, limber, good for us to go. And so we're going to pull that BVM off. And so I'm going to go in, lift the epiglottis with my McGrath, visualize the chords. We can pass the bougie in, slide the tube over, inflate the cuff, pull the bougie out. We're still holding that tube. We can pull the McGrath out. We can start ventilating. We're going to be listening epigastric sounds, bilateral chest sounds. Is the tube in?
Yep.
Cool. And so tube's in, so we're going to continue ventilating at a rate of a breath every 6 seconds, so 10 a minute. Going for adequate chest rise. We're going to secure that tube with Tom's tube holder. We're going to continue ventilating him. I'm going to call Ermac again and let them know that our friend now also has a tube, just so that they can be ready for that.
Cool.
And we have pulled up,
Cool.
and we're going to walk in there. The three of us, gigantic nut sacks hanging down
For sure.
because we feel like pimps. We'll give our bedside report, give them a little sayonara as we head out, and that's that.
Cool.